My video, yeah,
Yeah, okay.
that's good. Ah, Google Meet is so much easier.
Is it?
Hmm.
I mean, I don't know. I somehow often find it difficult to log in on Google Meet.
Yeah. Oh,
And this is just like one click.
Google Meet is half a click.
Yeah,
We always say click, no? The stuff happens when you unclick, not when you click.
I didn't get that.
We say no, when you click, something happens.
Hmm.
Actually, nothing happens when you click. It's when you unclick that this gets activated.
Oh, I got your point. Yeah, yeah.
Hmm.
So it's 7. So I'll just introduce you and
Yeah, let's start here. Oh,
hello everyone. This is Akshay Baheti, and it is an absolute privilege to introduce, the biggest influence in my radiology career, Dr. Ravi Ramakantan. Dr. Ramakantan was my HOD when I was doing my residency in KEM. He is Professor Emeritus in the Department of Radiology at KEM Hospital and Honorary Consultant at the Department of Radiology at Kokilaben, Mumbai. And he's pretty much the Bhishma Pitama of Indian radiology and the Krishna and the Arjun and everyone you can, use. And he, apart from, interpretation of images, I think what we learned most from Sir is beyond interpretation, how to become a good clinical radiologist, how to phrase or frame a good report, how to just, be a good human being. I think that's the first thing we learned from him. And today he's going to speak on this very important topic of how to frame a report. So he's going to speak on the language in the radiology report, the said, the unsaid, and the unnecessarily said. Sloppiness is not an option. So really, really eagerly awaiting this session, sir. We are doing a Saturday Night Light, something different after a long time, and it's it's so good that it's you who are taking this session. So
okay. Thank you, Akshay. I'll start now.
yes, sir.
Okay. It starts with this very simple question that we should ask ourselves: what in the hell are we doing in our lives today as radiologists? You interpret images, so what?
Sir, sorry to interrupt. Can you just make it full screen?
You want me to make it? I'll make it. Okay. Or I'll make it a little late.
Okay.
Okay. So when we interpret an image, it has no meaning at all unless those findings are conveyed to the referring physician. I never use the word clinician because we as radiologists are as much clinicians as clinicians are clinicians. So that's the first language problem. We always say referring physician rather than clinician because that sets up the tone of your understanding of what you are as a radiologist. Okay, so when you send a written report to the referring physician, which is most of the time the case, sometimes it's not read at all. They look at the images and they say, we know it better than the radiologist. Let's leave that part out of it. That happens, say, 20, 30% of the time, depending upon where you practice. A good 50, 60% of referring physicians will read the report. And that's where the problem starts and the solution begins. I'll take you to this slide, which is long, long ago. Now, these two are all-time greats in radiology. And they have been talking about the, let's say, business, not exactly the business, the whole scope of radiology as was seen long ago, 1995. Now, this is an article I would recommend to all of you interested in a little bit of history of radiology. I mean, you have to take interest in the history of radiology. When I used to do that even as a resident, I would go to the Tata Library because the Tata Hospital Library here in Parel, and that had a better collection of, and especially look for really old articles. And then you see how simple life was then. Anyway, that's beside the point. Now, in 1995, they cite a report of 1922 by this guy called Hickey. And he said in 1992 some very nasty things. And some of that is true very much today. I mean, you go through, I mean, honestly speaking, if I see a radiology report today, the chances of finding, in my opinion, a decent report is, let's say, 5 in 100. Report as I feel it should be. I'm not saying I'm right, but as I feel it should be. So that's what he said. It's impossible to form a diagnosis or even relate the findings to the clinical problem. That is the crux of the whole thing. Our being radiologists is because there is a patient. If there were no patient, there would be no doctors. If there are no doctors, there will be no radiologists. I'd be selling peanuts on the store. So once you get that into our head, once you get that into our head, that the business of radiology, of our day-to-day being, is about conveying what we see on radiographs or images, if you will, to the referring physician. I'm not even getting into the aspect of conveying those findings to the patient. That's a different talk, 1 hour talk on how to handle patients and convey reports to them. Now, sometimes, of course, we will, in fact, if you're teaching hospital, it happens all the time. Consultants would drop into the department and then chit chat a little bit and discuss half a dozen cases. That's a different ballgame altogether. You have consultants sitting with you, their whole unit is sitting with you, and they give you a whole lot of clinical information. Therefore, these meetings are very useful. And then you discuss the case. That's a different issue altogether. I'm not going to talk about that. I'm not actually even going to talk about the report itself, not about the structure of the report, not about how it should be worded from the point of view of the science of radiology. Now, whether you should call it impression, whether you should call it conclusion, so on and so forth, whether you should take the clinical information into account in the report itself or not, that is not my talk, because there are a large number of articles, a very large number of articles that touch upon or even go into the depths of how that report should be from the science point of view. Now, almost no one in our country has English language as the mother tongue, okay? Some of us may have as a mother tongue, but most of us do not have English as a mother tongue. Therefore, it's natural to expect that we will make mistakes of grammar, syntax, etc., when we write or speak English. There is absolutely no shame in that. Which population in the world can speak 5 languages? I can speak English, Hindi, Tamil, Marathi, and a little bit of Gujarati. And many of you will be able to speak 3, 4 languages. So there is no shame at all in not being able to speak good English or write correct radiology reports, which are correct grammatically and syntax-wise. I don't blame anyone for that. But there's a big but. When there is an opportunity to learn, to write properly, to describe correctly, and most of all, meaningfully, those who sit back and continue to do the same mistakes ought to be, I don't know what. If they are KEM residents, I would tell them 5 rounds around the basketball court. Sometimes I tell them what my math teacher used to say, I cannot forget it. He used to say, as a punishment, hey boy, come here, go to the nearest tree, find the strongest branch, take the toughest rope, and hang yourself upside down. I say that sometimes in our radiology sessions with residents, and I don't want to say that to consultants. I'll be probably shot dead here. But there should be a willingness, there should be pride. That's the word, pride, in being able to formulate a report which is not only right radiologically, but also reads well, is grammatically correct, and use the right language. Now, there was, I think he is no more, my all-time great hero from University of Texas at Galveston, Melvin Schreiber. And he used to write one-page essays under the title of Chairman's Corner. And that's the title I carried. I mean, I copied for my own Chairman's Corner. And in that, he used to talk about a lot about by the side of the language that we use. And he would say that the more adept you are in using the right words, the more easy it is to convey what you are actually saying. And I'll give you examples of that, actually seeing on the image to the referring physician. So it's important not only to say the right things as far as radiology is concerned, but use the right syntax and grammar. It's important in our country because many of us have not schooled in the English language. We studied our everything except English in our mother tongues or regional language. So science, chemistry, physics, mathematics, everything, history, geography, everything was in the regional language. Most of us do not speak in English at home. I'm repeating this because I've seen residents feel ashamed when they are not able to speak in English. And that's a common thing in our country. Those who speak in English consider themselves in a class apart, a class higher. It's not so. It's not true at all. Therefore, as I go along in this lecture, I point out some very do me not. If you read Clyde Helm's book on skeletal radiology, he has this beautiful word, touch me not lesions. So I copied from that. You shall not do lesions, or you should not do mistakes as far as the English language is concerned. They are simple junior KG rules. Do this, don't do this, do this, don't do this. And I hope at the end of the lecture, at least some of you will follow those rules because those mistakes happen repeatedly and commonly. And as I say, and don't misunderstand me, any idiot should be able to correct those mistakes overnight. Okay, so this is the background. Now, some of you may feel, what the hell? How does it matter? I make brilliant diagnosis. What's wrong if my English language is wrong? And that's why I use the word. There's no room for sloppiness. It's all how we are. Many of us in our country are kuch bhi chalta hai. Anything will go. What does it matter? This will also do, that will also do. And that's sloppy. And one of the ways to excel in whatever you do is to consciously be aware that I will not be sloppy. I will do my best to do the best that is I'm capable of. And that's what the great basketball coach, John Wooden, said. And this is for residents. He said, do not try to be better than somebody else, but try to do the best that you are capable of. And this is especially for residents who have come through battlefield of NEET or whatever, and they are battling with each other. Resident, don't bother. It doesn't matter. All those battles are over. All that you want to do now is the best that you are capable of. From what point of view? From taking care of patients. Exams will go, exams will come. You may pass, you may fail. Eventually, you will be a radiologist. And when you do become a radiologist, your prime concern should be patient care, not just the radiology report. The radiology report is incidental. You are here as a radiologist, and I repeat, because there are patients. So from all of this point of view, just the concept that I want to do the best that I'm capable of, I want you to listen to this lecture, watch a few slides with an open mind. At the end of the lecture, you can go back and do what you want. Obviously, I cannot do anything. I won't even come as an examiner for you, but I hope I'm able to convey the meaning that it's possible. It's very easy to write accurate reports without much effort. One slide down. I told Akshay long back. I had this lecture at the AOCR in Chennai recently. I was given a very precious 25 minutes to speak. Bhavin was the moderator. At 30 minutes, it was pre-lunch session. Bhavin said, Ravi, enough, enough, enough. No, Ravi doesn't listen to enough, enough, no to Bhavin. So I asked the audience, can I go on? And they say yes. So from 25 minutes, I made it 45 minutes, and I had done only half the lecture. So when Akshay said, will I give this lecture? I said, you keep it as the last lecture. And then Bhavin said, from 7 a.m. till end. Now, I don't know when this will go on. Of course, the good thing about video meetings is that you can walk out whenever you want to. Okay, now let me move on. I use something called the dog analogy because radiology reports are like dogs or asses or donkeys or elephants or cows or human beings describing something. Now, if you show this to a radiologist, this is what he likely says. This is a black colored animal which has a lot of fur. I can see that there are two eyes. A nose is seen between the two eyes. The mouth is partially open. There are two ears, but only one ear is seen well. This appears to be a dog, but the possibility of this being a wolf cannot confidently be ruled out. Therefore, repeat the image with the full animal seen. So the poor radiology resident with the technician goes to the dog to repeat a picture. The dog bites, and what happens? No rabies, luckily. And then you show this to a 3-year-old kid and say, baby, baby, what is this? Uncle, you don't know. This is a dog. That's what we do. We make simple things complicated. When we can use simple language and come to a conclusion in 3 lines, we go around with weather reports, and that becomes a habit. All our radiology reports end up being weather reports, and I'll tell you why with proof. So this is the dog analogy I use all along. When a resident is describing an image, I tell him, think of this as a dog. Use the language that you describe a dog, and don't get into convoluted English just because somebody else has taught you that English in the report should be convoluted. The possibility of this, that, etc., etc. So the simple analogy is that think of every image as a commonplace thing and how you will use your language for that. I'm saying this because when you sit back, close your eyes, and think of the language that you use in radiology reports, you'll realize seldom do you use those words, syntax, phrases in day-to-day life. Like I'm talking to you, you'll see that I rarely use those radiology words that we normally use or we are trained to use during the course of our residency. There's something wrong there. There's fundamentally something wrong, and that's tradition. I hope that it doesn't get embedded in our genes. Today I read something about trauma of war altering the DNA of mothers and wives, and that can get passed on. So I hope this radiology language is not genetically transmissible, but it would appear that it is almost transmissible from teacher to student, year after year, generation after generation, and thereby is the big tragedy. And that's what I'm trying to break. And when I take clinics for radiology residents and I say, I shock them, you won't believe what goes on there. It's like a junior KG class. So they will say something. I said, no, it's not like that. This is like this. Repeat after me 5 times. And in that lecture of radiology of MD, some student is repeating the same thing 5 times. 25-year-old woman, 25-year-old boy, 25-year-old whatever, whatever. They're repeating because to do this and break patterns is not easy at all. And I tell them that if not you, who? When 25-year-olds do not break tradition, who will break the traditions? And I feel those traditions have to be broken. So this is a dog, period. You can describe whatever you want, but at the end of it, you can't say the possibility or the probability of this cannot confidently be ruled out, so on and so forth. Simply say this is a dog. Now, the dog analogy is what I use to teach residents to describe radiology reports. Let's go on. This is what happens when this goes on the view box, right? You see the view box, it becomes a black furred animal, 2 eyes, 1 nose. cannot be ruled out, so on and so forth. And that is absolutely unfortunate. So this is in black and white, the dog analogy. Use it all the time when you are in doubt about what to say in words and phrases in your radiology report. Close your eyes. What would I have said if this was a dog? Makes life so much easier. Now, this is what I do. I mean, some of you who attended my clinics, lectures know that I do this all the time. Close your eyes. Please close your eyes. Because when you close your eyes, a whole part of our brain shuts down, more or less. You do a functional MR on a person who closed his eyes, the occipital lobes draw so much less oxygen. And the rest of it is being used by the rest of the brain. That's why when you pray, how many of us pray with our eyes open? We close our eyes. You're supposed to concentrate. Therefore, close your eyes. Listen to what I'm saying carefully. The image shows a sunrise. On the top left, at the 10 o'clock position, is the beautiful yellow ball of the sun, perfectly circled. Streaming away from the yellowness of the sun are shades of red, orange, and crimson. And as it travels towards the right of the screen, at the bottom right, at the 4 o'clock position, it fades into darkness. Open your eyes. Each of you, if your ears open and listening to me, has formed an image of what I describe. And I pride myself in saying that I can describe beautifully, whatever it is. Okay, you make your judgment on that. And you have formed an image of what I describe. Okay, now what the fun? This is the image. So you can, for yourself, compare of the image that you found as I was describing this scene to what you actually are seeing now. And give me 10 on 10 for my beautiful description. But that's not the point. The point is this, that when I was describing this image and you were not seeing it, you were forming a mental image using language and your past lived experiences. And that image is formed by visualizing what you hear. And what you do now is an image that you form when you actually see. The amount of temporal lobe and occipital lobe involved in both of these is sort of reciprocal, if you want to use that, approximately different. So whereas the temporal lobe is what comes into action when you're listening, closing your eyes, and imagining, visualizing, versus occipital lobe, and then a little bit of temporal lobe when you are actually seeing. Now, how often you make reports with your eyes closed, looking at imaginary words from nowhere at all, and then write the report? How often do you visualize a report and write the report versus how often do you see a report, see a finding and report? Never ever do we visualize and then write the report. We never visualize a movie. We never visualize a dance program. We never visualize something on the TV. We see. So too, when something is on the monitor or something is on the view box, we see, we do not visualize. This is so obvious. You go and talk to people, they say, oh, but, all of that is a lot of hogwash. We never ever use the word visualize in daily life when you want to describe when you're seeing something. Ask yourself, when did you say, I visualized a Hindi movie? Or I visualized you on the street? You simply say see. But when it comes to radiology, because of tradition or whatever, it comes down like this. And we always say visualize more often. Okay, that's wrong. We say visualize more often than see. The reason I'm bringing this one word is simple. We are making a big blunder of the use of language by using the word visualize rather than simply see, and we are not thinking about it. For generations, we are not changing. We continue to use the word visualize day in and day out. And it's only in the last maybe 2 years or so that I have made a serious effort to stop using the word visualize. The first 6 months, it was difficult. How would I say this? How would I say this? And now it comes to me naturally. I don't ever use the word visualize. Again, let me clarify. It's not about that word. You can always say, so what's the big deal? It's not about the word. It's about how we think and we work with the science of radiology. The tragedy of this, of course, it's very interesting. Now, this is not the first time I'm talking to people about the word visualize. I talked this across the coffee table, one-on-one, and everybody say, yeah. And I do not know of a single individual after several lectures, several coffee shops visit, who has stopped completely using the word visualize. There must be something happening there. Why do you not want to change? I repeat, not one person that I have lectured to, talked to, has completely stopped using the word visualize. There is a moral in that story. Moral for you all and moral for me also. Why does this happen? When we know that the word visualize is meaningless as far as seeing and writing is concerned. This is just one example of the foolishness of the language that we use. So I would say, and I tell this to residents, cease and desist. Do not ever use the word visualize in a radiology report. There is no scope for visualization. Absolutely none whatever. If you disagree with me, send me an email, raviramakantan@gmail.com, and we'll have a conversation on email. So this is one simple word that I feel should be banished from the lexicon of the radiology language that we use. No more visualizations. Okay. Now this is what it is about. You see something. Now the other example is this, that if you go to wherever you are, to a seashore, and then you see a sunset, so beautiful and glorious. You've seen it. When you come back and describe it at home to your children, grandchildren, wife, husband, whatever, they visualize it. That's what I'm trying to say. That's imagination. The parts of the brain that are involved are very, very different. As I told you, reciprocal. This is the actual English language meaning of the word visualize. And I bet there are people in the audience who are disagreeing with me, saying, no, but this, but that. My simple question to you is, when you start using the word visualize in non-radiology conversations, then I will agree with you. Okay, let's move on. So I can't be more emphatic. Banish visualize completely. Okay, now I'm going to show you a picture, okay? And I will describe it. Both boys are in t-shirts. Both boys have half pants. Both boys have plates in their hand. Both plates have some yellow stuff, and both boys are eating, and both boys are sitting on a sofa. Correct? That describes it. That describes everything. But when it comes to this bilateral frontal sinuses, bilateral maxillary sinuses, bilateral turbinates, bilateral this, bilateral that. Why? Why does it become bilateral when it comes to radiology reports? And then somebody says, no, no, sir, it's slightly different. We say bilateral because there is something here dividing and they are on the two sides. Therefore, this is bilateral is right, and that is not there. Therefore, it is both. Wonderful. What about this one? Bilateral dogs are being walked. Bilateral dogs are in leash. Basically, the word bilateral is totally, completely wrong to use for the word both. And I'll show you later on a school lesson in parts of speech. There is no need to say bilateral here. It's just tradition. It's a bad tradition. It's much simpler to say both maxillary sinuses or both maxillary sinuses show some mucosal thickening. Both frontal sinuses are normal. By the way, I mean, let me finish this off. You use both when you want to say something positive. You can't say both frontal sinuses are not seen. That's wrong English. When you want to use the word no, none, or any negative, you say neither frontal sinus is seen. That's a different ballgame altogether. Let's get rid of this both business. So when you want to say bilateral at the beginning of the sentence, close your eyes. Say, I shall not use the word bilateral ever in my radiology report, and you will be safer and more correct. So whenever I want to use bilateral, I will say both, and you will be right. And if ever you want to use the word bilateral, begin the sentence with bilaterally or end the sentence with bilaterally. For example, here, mucophyseal thickening is seen bilaterally. Okay? And again, see, look at that. Seen bilaterally. I'll come to the voice, the active voice or the passive voice. So, like I said, rule number one, RR rule number one. I am very pompous. RR rule number one of the English language used in radiology reports. Do not ever use the word visualize. RR rule number two, do not ever use the word bilateral. There is no need. You can say both. In fact, it's wrong to use bilateral. And why is that so? Do I have a slide for that? Okay. This is back to school. So these are different things altogether. So when you want to say right maxillary sinus and left maxillary sinus and both, they are pronouns. That's what you want to do. Instead of saying this and that, you are using a pronoun. This boy and that boy, both boys. Whereas bilaterally is a situational aspect on the right, on the left, and therefore it's an adverb. Goes above your head, don't bother. Don't go back to school. So this is fundamentally wrong. I mean, it's wrong in English language. You'll find it in a large number of reports, very large number of reports, sentences starting with bilateral rather than both. Rule number two, banish the word bilateral completely from all your radiology reports. Let's move on. Okay. Yeah, that's what I wanted to say. The next one is this. It's very interesting. This article. So this is a definitive article and there is a non-definitive article. You're the and a. Okay. And I had a friend who was all along with me in MBBS and he retired as the head of Department of Gastroenterology at KM Hospital. He was also the editor-in-chief of the Indian Journal of Gastroenterology. Sense of a guy with a very subtle sense of humor. You keep listening to him and then you can smile or laugh. And he said, Ravi, you know something? I see this whole lot of submission that come to me and I'm impressed with the number of articles the number of articles is perfect, absolutely perfect. There is a the when there should not be a the, and there is no the when there should be a the. Now, this is something you learn by speaking English, okay? Now, if you ask me why there is a the there and why, I wouldn't know. I can't tell you grammatically, but there are simple rules again, very simple rules. And I want you to follow that. Ravi Ramakantan's radiology reporting rule number 3. First, and most important, and people make mistakes in that, I don't blame, because you are not an English language speaker. Whenever you want to say patient, whenever, without exception, say the before that, and you will be right. Whenever you want to say patient, patient came with pain in the abdomen, my head bristles. Because it's a simple rule. There is always the before a patient. The other rule is also as simple as that. Whenever you want to describe an anatomic structure, use the before that. Without exception, without almost maybe one or two in 1,000 may have exception, don't bother with that. Without exception, use the maxillary sinus, the right maxillary sinus, the inferior wall of the right maxillary sinus, the right kidney, you can say the inferior pole of the right kidney. So whenever there is an anatomic structure, use the before that and you'll be easy. And again, people are thinking, what is going on here? He's telling us about I come to learn radiology here. What's the big deal about I told you that these are simple rules where you can make your report more easily readable. Also, more important, when you send out manuscripts for publication, I don't know if you know what exactly goes on. So let's say we get 100 publications, 100 articles for publication. It usually goes through an editorial secretary. She goes through this, and then she's experienced to say that this is written properly. This is written properly. That means the structure is right. All the do this, all right. And then it comes to the editorial board. The editorial board looks at the main parts of the article and says, okay, this is something that can be looked at. And then it goes to one of the editorial assistants or members of the editorial board, and their job is to look at the article. And I was doing that for the Indian Journal of Radiology for sometimes a couple of years. When Dr. Mukund Joshi was the editor-in-chief, I was doing the secretarial work. And the one thing that gets your goat day after day, you have to sit and correct the English language. And then you say, go to hell, I'm rejecting this paper. So send it back to the author saying, please refer to an English language expert and correct all the English language mistakes. So sometimes it will get rejected just because the English language is improper. And one of the common and universally present mistake in our writing is the way you use or don't use the article the. So in radiology reporting, you start doing this, two things, the before patient, the before anatomy, and maybe 80-90% of your mistakes will be gone. Your report will be more readable. So you have already corrected 3-4 common mistakes in the language. Okay, now the next thing is using the appropriate word. I was talking to somebody that day. In Marathi, there are two words, Pushkar and Bharpur. And I'm sorry, some of you maybe from outside Maharashtra know the language at all. And both of them mean many. In fact, I asked, I'm not a Maharashtrian, I'm a South Indian. I asked Maharashtrians, what is the difference between these two words, Bharpur and Pushkar? And they had trouble telling me what that is. So one is many or large amount, large in volume or uncountables, and the other is countable. So like we say it's raining lots, okay? Raining a large amount. And otherwise you say there is a big crowd, something like that. Where it can be counted, where it cannot be counted are two different words. Now, when you can do that in your native language, you should be able to use these correct words rather unusual in normal language, but convey an important meaning. Now, the problem, and it's a justifiable problem, is that you tell us to use these words which we have never heard in your life. You use them in the radiology report. Who is going to understand? Valid suggestion. But that's how change happens. Somebody has to start using the right words, and slowly, slowly, the language will change because these words are perfect for those circumstances. Now let's take the first one. I tried to get examples. I mean, I use these words fairly commonly in my X-ray reporting. Let me look at that. In fact, except the word trifle, the fourth, fifth word, I use most other words at least once or twice a day, even today. Okay, and just in critical care X-rays. So let's use the word straddle. Straddle. Saddle is like the classic example when you're sitting on a horse on a saddle, your legs are on either side. And that's called straddling. And how does it work? We'll see about that. Overhangs is how do I describe it? If I'm talking like this, my wife comes back and stands on my back and is looking like this, she's overhanging. Abuts is stuff. This is abuts. There's something here, something comes at that, it abuts. Impinges is an exaggeration of abut. It comes, does this and does this to that, and that impinges. Embedded is simple. All of us know. You take, how do I explain that? Let me think of an example. Double back. Something goes like this and comes back like this. That's doubles back. I mean, it makes a double turn and comes back on itself. And these are specific, simple words which can actually describe the exact situation on the radiology report image. And let me see if I have got examples of each of them. Okay. Is this what I wanted to say? Okay, let's see. Now look at the image in the center. There's an endotracheal tube, and just below the endotracheal tube, there is a sternal suture, and at that junction, there are the main bronchi. So I would use the word, the tip of the endotracheal tube overhangs the origins of the main bronchi. It's a big deal, okay? It's not supposed to be there at all in the first place. That's a different ballgame. So when it is overhanging, and I don't know if you people, I'm talking to residents, I mean, consultant, please excuse me. If residents spend time with looking at that hardware, look at an endotracheal tube, and I'm sure you know that it's not like this, it's sloping like this. So depending upon which side is what, something that is overhanging can get in to one or the other bronchus just by movement of the neck. It's not funny. It can change very easily. And if the pediatric case, it's dangerous, downright dangerous. So when you say it's overhanging, it means that it's wrongly placed. That's all. You have to change it. So that's what we mean when we say overhanging. Now, the one on the left, extreme left, on your extreme left, is a nasogastric tube, which is at the pylorus. Okay. I'm not sure which part of the tip of the tube is in, whether the tip of the tube is exactly the pylorus. The word pylorus means pyloric sphincter. I mean, that's by Gray's anatomy. Pylorus means the sphincter. It does not mean the pyloric antrum. So whether the tip of the tube is in the duodenal side or just in the pylorus, and we know that the proximal side holes are all in the antrum and the distal stomach. So I would use the word, the tip of the nasogastric tube straddles, S-T-R-A-D-D-L-E-S, on either side, on both sides, what do you want to say, of the pylorus. And that's not something that you want to happen. We know that there is a particular science behind positioning of the nasogastric tube. Give me another hour, Akshay, and I talk about positioning the nasogastric tube. It's great fun. So this fellow, with the tip pointing to the duodenum, is getting duodenal contents back into the stomach through the side holes, and then you have antral gastritis. So something that is straddling the pylorus is not the position of the nasogastric tube. And something else is overlapping on the other side, on the extreme image. The image on your extreme right, it shows the nasogastric tube coming down from the 10 o'clock position. It goes down to the 7 o'clock position and travels to your right from the 6 o'clock to the 4 o'clock position. This fellow, the nasogastric tube, is embedded in the rugae of the greater curvature of the distal body of the stomach, listen to the words, is embedded in the rugae of the greater curvature of the distal body of the stomach. And this fellow, if this tube is embedded there in the pediatric age group, all the side holes are blocked and it's doing nothing. And there is mucus there. It sort of acts like a vacuum seal. So a tube like this is wrongly placed. No tube is supposed to travel along the rugae of the greater curvature because they will secrete mucus and the whole tube gets blocked. So you say it's embedded in the rugae of the greater curvature of the distal body of the stomach. That's national anthem for me. I keep doing that all the time. And slowly, my pediatric colleagues understand what I'm talking about. So you see this, look at the stomach, it's still distended. Why is it distended when so much of the tube is inside? Because all the side holes are blocked by the mucus in the greater curvature. I told you, the science of the nasogastric tube is really great fun. And here on your extreme left is a central line which comes all the way to the right border of the superior vena cava. I'm not using the pointer because I pride myself in being able to convey in words what should be seen by your eyes. So the left central line travels towards the right, and it goes and hits against the right wall of the proximal SVC. Not a good position to be in. Most of the time, nothing happens, but it can so often happen that one, you take a pressure of this venous pressure, it's a damped pressure because the end hole is blocked. And then you try to flush, you can create subinguinal dissection. And worst of all, this fellow, if you're very unlucky, very, very unlucky, can perforate the SVC. So I will use the word it impinges the right wall of the proximal SVC, which means, for God's sake, do something about it. Now, what is the next one here? Oh, yeah. Now, if you look carefully at the central image, this nasogastric tube comes down up to the level of D8, D9, D10. It looks like it is at D5. No, follow it carefully. It goes down first and then doubles back on itself. That's what I wanted to show. It doubles back on itself and comes back at D4 or D5 where the tip is. Now, this is not very bad. I mean, you inject something, it comes back into the esophagus. That's a dangerous thing. But if this is happening in and out of the stomach, right? This fellow goes down into the stomach and comes back into the esophagus. It's not a good thing at all. Okay, I'll move on with the next slide. Let's see. Now, this is another thing that I wanted to tell you is about how often we are confident of using confident language in the radiology report. The universal truth is that we don't do it, right? The possibility, probability appears to be all that. And I'll give you examples of that. I'm not talking Hawame, okay? I'm talking the truth from data. So when you write a radiology report, you should try and avoid platitudes. I don't think platitude is the right way, but platitude for yourself. So you feel that if I say it appears to be rather than it is, you are legally safe. No, you are not legally safe by the language that you use. Never. What courts will look at, this is important, your language will not protect you in a court of law for malpractice affair. The courts of law or consumer courts look at only one thing, whether what you have done is compatible with the standard of care by the general body of radiology that you do. For example, if you have that nasogastric tube there and you did not say that it is not in the stomach, you're in trouble. If this patient aspirates, get into some trouble. That's the standard of care. Similarly, if you have a CT scan and you missed a hemorrhage or you missed something else, a herniation of the across the fox, whatever, something which is very obvious, that is the only thing courts go by. Your language, your disclaimers, nothing will protect you in a court of law. Therefore, do not hide behind platitudes in words, and I'll give you some examples of that. This is what I'm trying to say. Our radiology reports are often like weather reports. The weather fellows are lucky because they get immediate follow-up. They say it may rain, and then they can stand outside on the tower there and see whether they were right or not. For us, that's not so. So we have to learn lifelong learning of whether we are right or not. Now, what is the story I want to tell you? Okay, oh yeah, this is very interesting. So we have a couple of us, 3 people sitting in the PACS room and running the reports. They come like a factory. And one of these guys, my colleagues, was talking on the phone. He's an abdominal radiologist. And he was talking on the phone to somebody on the other side. And it's speakerphone. I don't like it, but people use speakerphone. So he was saying, can this be appendicitis? He was talking to the other guy on the other side. Can this be appendicitis? And came the reply on the speakerphone, sir, the probability of that possibility exists. The probability of that possibility exists. The conversation got over and I said, you're talking to a radiologist or what? He said, no, that was a surgical resident. Then I said, I'm sure one of his parents is a radiologist. I mean, I could make up a story and say that they were radiologists, but I didn't check it out. But this thing about possibility or probability is quite simply amazing. We are hiding behind words that will not protect us in medical legal situations, and words that simply don't convey anything. That was the story in 1905. You saw that slide. It cannot be the story in 2025 and technology is so much better. So this is about possible and probable. It's possible that as I talk to you, the power supply in whole of Bombay will go. It's possible. That's the word possibility. But it's not probable. The possibility is possible. Anything is possible. Virtually, there could be a tsunami in the Arabian Sea in the next 2 hours. It's possible, but it's not probable. The probable obviously takes into consideration what has been possible before, now, and history. So it's better to use the word probable rather than possible in radiology language. So there is no scope of saying possible because anything is possible in life. Anything is possible in life. I may even talk sense. That's also possible. Is it probable? Very unlikely. Let's move on. So that's what that fellow said. Now, these are the words you should stop using. I simply have crossed the damn thing out. Now, gross abnormality, the liver is grossly enlarged or something like that has no meaning at all. The word significant usually has a statistical meaning. So when you want to say significant gross can always be described in numbers, right? And the word gross means different things to different people. There are multiple meanings. Now, significant is something that people use again to hide their backsides against uncertainty. Unremarkable. What do you mean by unremarkable? What do you actually mean by unremarkable? A chest X-ray is normal, it's normal. If the abdomen has gallstones and the rest of the abdomen is normal, it is not normal. It's not unremarkable. If it was remarkable, you are supposed to have remarked on it. So when you say unremarkable, it has no meaning at all. Absolute hogwash. Stop using unremarkable and say it's normal, or say that there are no findings of significance. That's useful. For example, in chest radiology, you get diffusely increased vascular markings and say they are of no significance. You say these markings are of no significance. I sing a song. The diffusely increased vascular markings in both lung fields is normal for the patient's age. So you can actually say that. If you're dictating, it's so much easier to say that. So don't use the word unremarkable. It's hiding behind nothing. You will still be naked if you use those words. Epicentre, oh my God. Now, epicentre is a new word. I've been hearing it for the last 5, 7, 10 years. And it completely shows your ignorance. Excuse me for being harsh. Whether you're a teacher, whether you're a student, using the word epicenter after this lecture will mean that you go to the nearest tree, find the strongest branch, take the toughest rope, and hang yourself upside down. Because it's so wrong. Totally, completely wrong. Do you even know what epicenter is? All of you know what is epicenter. Because the word epicenter is broadcast, like for example, yesterday, day before, there is an earthquake and there is a epicenter. Epi means on top. So when you have, and I think I have a slide for that, let's look at this. So if there is a tectonic plate movement below us and plates crash and there is a maximum effect at a point below the ground, okay, below the ground, 100 feet, 100 miles below the ground, and it is felt, for example, where I am sitting here, so the epicenter, above the part above the center, where the event is occurring. So there is no such thing in radiology. Everything is a signal plane. So the epicenter is in the, let's say, the head of the coordinate nucleus. There's no such thing. So you simply say centered around the head of the coordinate nucleus. There's no word called epicenter. It describes a complete lack of understanding of the word epicenter. Third word, stop using, cease and desist, using the word epicenter. No place in radiology language. I hope you understood what I'm trying to tell. Epicenter is when you're talking of geology and earthquakes. There is no other word or use of word of epicenter, and especially in radiology language. There is no epicenter. Stop using the word epicenter. So when I say stop using, like for example, visualize, it's not easy at all. Those of you who have been using these words for hundreds of years, let me say hundreds of years, will find it very difficult to stop using it. It takes an effort. You should say that I want to stop using it because it is wrong. Unless you have that commitment to using the right things, especially if you're a teacher. If you're a teacher, you continue to use the wrong thing, I don't know what to say. One more time, nearest street, toughest branch. But somewhere this chain has to be broken. Now look at this. And now look at this. The image on top, it clearly shows it's raining, right? It's raining. The image at the bottom is evidence of rain. You cannot say there is evidence of rain on the top picture. There is no evidence of rain. There is raining. For God's sake, it is actually raining. I can see it. So it is raining. And here the floor is wet. Therefore, it's evidence of rain. I cannot actually see the rain here. So evidence of should be used when you want to say evidence of and not when you actually see. When you see blood in the deep gray matter, you don't say there is evidence of blood. There is blood. There's no evidence of bleeding. There is bleeding. So again, evidence, for God's sake, we use it so wrongly, so often. It's simply that we have stopped thinking when you use this word. I mean, it's not as if we use it consciously. It's unconsciously, and we don't think that this is stupid. Let's stop. So when you use the word evidence of, like this, for example, yeah, look at those surgical clips. So this is evidence of lap cholecystectomy, and you'll probably be right. You can't see the cholecystectomy here, which you'll see on ultrasound, but on plain film, it's evidence of surgery over the gallbladder fossa region, something like that. So you should know when to use evidence of and when not to use evidence of. This word appears to. Now this is another big thing. Appears to be, everything appears to be, this appears to be a dog, this appears to be a camel. Use it only when required. Okay. Now let's look at this. Now, if you said this appears to be a sparrow, I'll probably let you go. Okay. But if you say this appears to be a sparrow, I will shoot you. The word appears has two contexts of meaning. So when something comes into this, now if I can see something here, for example, a spot of light here. There's a spot of light. A spot of light has appeared here. So that's another thing. That's a verb. But when you say appears to be, because you're not sure, then it's fine, like the image on the top. But if you say appears to be here to protect your backside, I will shoot you. My bullets are running out. So again, people use the word appears to be when they are wanting to protect yourself, but it's possible that you should use the word appears to be. And unfortunately, I didn't get that example. It's a daily example. When there's a pleural effusion on the right side, pleural effusion on the left side, and you vaguely see the cardiac shadow, then you can say the heart shadow appears to be enlarged or appears to be normal because you are not seeing it well. You think you see it, but you're not seeing it well. So then you can say appears to be. But you cannot say nice lung on this side, nice lung on this side. The heart size appears to be normal. Not allowed. So be careful when you use the word appears to be. And the underpinning thing of all this, that you should not think that by using the word appears to be, you are getting away with legal complication. You will not be protected by using such words. And appears to be like this. This appears to be an elephant. No, this is an elephant. The elephant has appeared. So that's a different meaning. Top and bottom. Maybe appears to be is allowed in a sparrow on top, appears to be not allowed in the sparrow at the bottom. Now look at this damn thing. Now, people will look at this, look at everything, and then if you say, this appears to be a normal lateral view of the cervical spine, not acceptable. Because you then have to tell me why you say this is not a normal, what makes you think that it only appears to be, what you actually mean is that this is a normal cervical spine. So why don't you say this is a normal lateral view of the cervical spine? So, like for example, a normal brain, okay? No abnormality seen on the CT scan of the brain. Why? Why don't we say the CT scan of the brain is normal, which is what you do? Again, and I repeat it again and again. By seeing no abnormality seen, you will not be protected in a court of law. I said it 5 times, 10 times. So my friend, a good friend of mine, is a medical legal lawyer, and he says, you idiots, you think you can get away like this or what? You will not get it. And he banged this into my head, saying that language does not save you from medical legal complication. So when something is normal, say it's normal. More importantly, let's look at this word. Oh, this is fun. It's absolutely fun. So we use the word in situ all the time. So working with radiology residents is great fun. Sometimes it's really, really great fun. And this was one example. So somebody was writing there in situ. So I asked him, do you know what situ means? Blank, blank glare. I said, okay, tell me the spelling of situ. In situ. No, wait, what happened? Oh, God, something happened. Yeah, that's it. So he then said in situ, CITU. I said, are you sure? I'm a bad examiner. Are you sure? And then he said, no, sir, it's situ. So residents go around in circles. Now, I want you to understand the meaning of the word in situ. This word comes from archaeology or from civil engineering. So when you have something on your left, excavation site, yeah, and you find artifact there, and they would say that artifacts were left in situ, in place, in their own place, in their own original place. Okay, that's in situ. Like here, somebody is polishing the tiles. The tiles were polished in situ. The tiles were polished as they were, in the place that they were. So what is the two important things here? That you use the word in situ, in situ, when you want to describe when something in its proper place or original place. Okay? So to say that the nasogastric tube Oh yeah, talking about imaginative answers, and I said in situ, in situ. This is another thing that happened. So this was another clinic I was taking, and the resident was describing this, and he said, this fellow's tetralogy. Sir, there is a right-sided aortic arch. I said, brilliant. Not often that residents pick up a right-sided aortic arch. I said, why do you say it's a right aortic arch? He didn't blink an eye. Sir, because it's not a left-sided aortic arch. Have you heard that before? The right aortic arch, because it's not left aortic arch. I was laughing so much that I didn't ask him the real reason why it's a right aortic arch. Now, this is just fun. I mean, if you teach kids, you come to know a lot about a very funny way that they can answer things. Okay, now look at this C2 business. So when you see a nasogastric tube like this, you don't say the nasogastric tube is in situ. That word is not to be used at all. Not to be used for any tube anytime. I'm being categorical about it. Because the meaning is completely different. For example, in nasogastric tube, you cannot say it is in situ, rightly or wrongly. You're supposed to say certain things about where it is supposed to be. The tip is here, or the side holes are here. Saying that it is in situ or it is in its place is wrong as far as nasogastric tubes are concerned. You should know then what is the actual physics of nasogastric tube placement. That's a different thing. But, and I'll tell you when you use the word situ. So when you see a tube in a particular place, don't say it's in situ. It's wrong, completely wrong. On the other hand, you see something like this. For example, this is a nasogastric tube that's embedded in the rugae of the greater curvature, and then you do this. So the correct phraseology is a contrast study of the upper GI tract was done with the nasogastric tube in situ. That means you are not telling the original place of the nasogastric tube. You are saying that I did something with that tube in its place. You didn't change the place of the nasogastric tube. So in that context, there is no scope for saying the word in situ except when you are on follow, right? So if you have a nasogastric tube, tell exactly where it is. If you have an endotracheal tube, tell exactly where it is, so on and so forth. And what will happen when, for example, you have a chest tube? It can be anywhere. So the right way to use it, and the one that I use, is the right chest tube is in an expected position. It can be anywhere, right? It can be up on top there. It can be down in the posterior costophrenic angle recess. As long as all the side holes are inside the chest wall, it can be anywhere depending upon where the surgeon wants to be. So you expect it to be there or here or here or here. So when you can't actually pinpoint where, for example, the tip is supposed to be, I use this phraseology for the last year or so, a little longer. This tube is in an expected position. And means it can be in 100 different expected positions, but it's that means you don't have to bother about it there. That's all. Sometimes some surgeons are particular where they want, and if you have conversations with them, you know that it is supposed to be here, it's not supposed to be here. Then you can say that it is not. For example, at the apex of the right hemithorax, so on and so forth. But otherwise, in non-specific tubes, let's use that word. Non-specific tubes do not say in situ. It's a wrong meaning, wrong word. I don't care who uses it. It's wrong. And I showed you example of what in situ actually means. Let's move on. What's the time now? God's sake. Okay. Oh. So this is what I was talking about. This is a post-sternotomy patient, and there is a tube that goes up to the apex of the right hemithorax. So this is what I said. The tip of the drain is in an expected position. That means you don't have to bother about that. Okay. And tense and what? This is another thing. It's so simple. It's so commonsensical that people still make mistakes. Now, if you see, let's see some examples of that. I think so. These are some of the of a report that I do most of the time. Look at the thing. The sternotomy has been closed. Active voice. There are no gauze markers. Active voice. so on and so forth. And you see that there is no passive voice at all. No gauze markers are seen, or plate atelectasis is seen. We tend to use a lot of passive voice in radiology reports. We start using active voice. The words are smaller and it reads much better. For example, no gauze markers are seen versus there are no gauze markers. Again, it's the same thing. It's trying to hide behind language. And I'll give you a classical example of hiding behind language, which I am also guilty of. A radio opaque shadow of 3 millimeters length is seen overlying the arch of the aorta. The appearance and significance of that is not apparent. Okay, the passive voice. What will be active voice is that I do not know the significance of this finding. Now, at 72, I have still not used that word. One day I will use it. I do not understand the significance or the importance of this shadow. I have to do that. But it's like this, we use the passive voice trying that will save us. For example, there are so many things here. No abnormality is seen in the claustrophrenic angle. So I have come to a situation where I am able to use simple active voice. I mean, simple present tense and active voice in most of what I use. That means what? Now I have an image in front of me. I'm looking at the image. That's present tense, right? When you are looking at an image and looking at findings, it's there in front of you. So there is no question why you should use any other voice. It's simple present tense because you're saying it. There is a dog in front of me. Some people say a dog was saying. Some passive sentences, past tense is used sometimes when using radiology reports. The past tense is acceptable only when you are, for example, describing something dynamic. For example, in ultrasound, which you are not documented, right? Interlesional vascularity was seen. There is no image to show that. Or the esophageal motility was disturbed. Past tense. That can be there when you're seeing something, not documented it or non-documentable, and then you can use the word for past tense. The other one that people now do, and this is something new, I don't know where these new fellows come from. The tumor is pushing the lateral ventricle. For God's sake, is it pushing now? Is it doing it now? Why do you use present continuous? Pushing is present continuous. So you simply say the tumor displaces. Don't say it's displacing. So that's not such a big deal, but active versus passive is something that you have to change. Do not think that passive voice will protect you, and use simple present tense rather than mixing up past, present, future, everything. Simple present tense. Like this. This is a classic example of only simple present tense. Hemorrhage is seen. It's simple present tense. Oh, this is too much only. Too much only. That's Bombay English. Too much only. People do this. Under view. On this image, there is absence of. Now, under view and on this image is, how stupid can you get, right? Whatever you are doing is what is under view. Whatever you are doing is on this image. Again, when you say bones under view are normal, you're trying to say that I don't know about the other bones. Obviously, you don't know about the bones. You're not expected to know. So you don't have to say under view. And you don't have to say on this image. For God's sake, you're reporting this image. So you don't have to say on this image. So the first two go out of your lexicon. That you don't have to say that. You will not protect you again and again, again and again. I'm saying this, that language will not medico-legally protect you. And that is the basis of all this horrible language that we use in radiology reports. I use the word horrible forcefully, meaningfully, and I hope that at least some of us will change that. There is absence of, come on, this is completely ridiculous. What do you mean there is absence of? You simply say it's absent. Why do you have to say there is absence of? I mean, this yesterday I read something. There is absence of opacification of a part of the internal carotid artery. Why do you want to say such complicated, convoluted English? A part of the internal carotid artery is not seen. It's simple. So when you use such convoluted English now, you have to think, is that the right thing to do? Is there a simpler way of saying things? Okay, now what am I showing off? Oh yeah, this is interesting. Now we often use, and this is I think a very important part of the whole thing. Oh God. I promise you another 5-10 minutes, I'm done. Suggestive of, suspicious for, indicative of. Why do we do this? The cardiothoracic ratio is 70% suggestive of cardiomegaly. Does it make sense? Radiodense material of Hounsfield-Duras 130 is seen in the capsular region, suspicious for, suggestive of hemorrhage. Doesn't make sense. These are not suspicious for. These are not suggestive of. These are. They are indicative of. So indicative of hemorrhage, indicative of cardiomegaly. There is no suspicion there. There is no doubt at all. So when you are sure, like probable, possible, avoid those words unless you have to. And I'm sure there are situations where you have to use this, but routinely using the word suggestive of or suspicious for, go back to your last 10 reports and see the number of times you have wrongly used the word suggestive or suspicious of, and in your heart of heart, you know that I use that because it will protect me from medical legal problem. It will not. 10 times I've said that so far. So you can use the word indicative of. That's simple. I go one step further when I can, and I use the word. Do I have that slide? Diagnostic of. And I do this not in unfrequently or not infrequently. Diagnostic of. Close your eyes. Think, when was the last time in your radiology report you said these findings are diagnostic of? That means you are sticking your neck out. You are giving a pathological diagnosis. And I am showing off. So I went through our packs and I went through 7 lakh reports of 14 radiologists. It's very easy. You just say from this day to this day, search for the word or the phrase diagnostic of. You get the result in 1 minute. And we have 15 radiologists in our department, very fine young people, very motivated, learned. Some of them are learned, others are well read. And in spite of that, all those 15 instances are by Ravi Ramakantan. I am not kidding. I'm giving you proof that I was the only guy who used the word diagnostic of when something was diagnostic of. Why don't we do this? And I'll give you some examples. Now here you see increased density of the capital epiphysis on the right side. The left side is normal. And maybe you would say that it's suspicious for osteonecrosis. On the right side, it's classical, open and shut, undergraduate, junior KG, Perthes disease, diagnostic of Perthes disease. You don't beat around the bush. You don't need an MR to say that this is Perthes disease or osteonecrosis. Maybe you would be excused or indicative of, suggestive of, whatever, for the image on your left. Look at this now. And this one. Now you may be perhaps excused for saying that the image on your left is suggestive of osteoma, but the possibility of chronic osteomyelitis cannot be ruled out. Maybe you would say that. I don't remember what I called it anyway, but I would probably call it diagnostic of osteoma. I'm sticking my neck out. The image on your right, there is no doubt whatsoever that this is an osteochondroma or an exostosis. Diagnostic of an exostosis. But what we cannot be sure of is whether it's a chondrosarcomatous change in that. Can say that. that this is an exostosis or an osteochondroma, don't use the word suggestive of. When you use suggestive of here, and I'm sure you are not meaning that you're not sure. You're just using it at a spinal cord level, suggestive of. So be conscious of using those words when you have to, and not using those words when you don't have to. Clinical correlation, God's sake. For God's sake. How would you feel if you get a request for MR sonography, okay? And the referring physician neurosurgeon says, please correlate with skull X-ray, please correlate with skull, plain CT of the skull, please correlate with the contrast brain examination, please correlate with plain MR. How would you feel? That's not his job. You will do it anyway. So to tell a referring physician, correlate clinically is plain, simple, unadulterated stupidity. That's not your job. He will do it if he wants to do it. What you're trying to do here, that you say that answer, I don't know. Tum jo karne ka karo. You do what you want. That's not fair. Some people go beyond. Some people are full all-time great. If I had a Nobel Prize, I'll give them. Suggest clinico-pathological correlation. What is that supposed to mean? What does that reflect of that human being who says suggest clinico-pathological correlation? Extrophy of the brain left somewhere, got cut off in a haircut. What is that supposed to mean? And clinical correlation does not protect you. So the best thing, if you're in an institution, you can call up, do something like that. And how do I avoid using the word clinical correlation? By saying clinical correlation, you are passing the buck, okay? Which is not required. That guy is going to do. As far as I am concerned, what is it that I want to say? This is what I want to say. I am saying that this is an osteochondroma, suspicious for chondrosarcoidosis changes if clinical findings match, or in the right clinical setting is diagnostic or suspicious for consistent with an osteosarcoma. Because just by looking at the image, I can't tell. And it's not always possible to get the history from patient. So what I am saying is this, that if this happens clinically, then this is possible. I'm not telling him go and do clinical correlation. Similarly, the word, many people do that. You know, you've seen this radiology request form. They don't say radio. We ordered a CT scan. It reflects poorly on the fellow who says I ordered. He doesn't understand what radiology is all about. No one can order a radiologist to do something because the radiologist, from the point of view of radiation safety, from AERB, from IREA, is supposed to decide what to do where. Okay, that's a different point. That it's a sense of how you treat another human being. So I would suggest that when you want something to be done by the referring physician, do not say advice. Forget the spelling, CE or SA. Do not ever say advice. You advise a patient. You don't advise a colleague. You say recommend, you say suggest, you use such words because that's courtesy. If you are not courteous to your clinical colleagues, how can you be courteous to patients? So the language that we use in our radiology reports reflects who we are and how we are brought up. Therefore, I feel that some of the things that I've said, which are open and shut, I hope some of you will follow this. This is Sir William Osler. And I always show him in my lecture because he said this. I am protecting my backside. Half of what we have taught you is in error. What I have told you may be in error, and I can't tell you which half it is. It's such a beautiful quote from Sir William Osler. And I think some of you are really keen and have nothing else to do on the weekend should look up the famous quotes of Sir William Osler. Now comes the difficulty, really difficult. So I talk about this to the residents day in and day out. and they write this case of the day or whatever, and they make these mistakes again and again and again and again. And they tell them, have I not told you so many times that this is not supposed to be like this? And then, sir, what can we do? You say do this. We go and sit for reporting with other consultants, and they say that, and then, and then, and then. That comes where the role of teachers comes. If we have to truly bring about change, teachers have to realize that there is a right way and a wrong way of doing things. And I use these 4 lines in every lecture these days. Many of you may have seen these, but these are beautiful lines for those who have not heard of or seen these 4 lines. No written word, no spoken plea can teach our youth what they should do. Not all the books and all the shelves. It's what their teachers are themselves. So if we have to bring about change in anything at all that we do at work, or sometimes even beyond that, the teachers have to change. And that is what I'm hoping, that today, tomorrow, or whenever we are able to break patterns and create change slowly, like the hour hand on clock. The hour hand of the clock is always moving. Change is always happening. We may not see it, but 1 year later, a decade later, we'll see that there is change. For that has to happen, teachers have to change. Now it's all in your hands. Thank you. Akshay, I'm done.
Thank you so much, sir. And I mean, the last lines just resonate so much with, I think, anyone who's worked with you. It's just seeing you day in and day out that has shaped us in those 3 years in radiology in KEM. This was a wonderful talk, and uh, I think most of the attendees, I'm sure, will at least incorporate some of what you have, recommended, if not all of it. Let me see if there is anything in the Q&A. So a couple of questions. If
Yeah,
if
sure.
Dr. Sumitra Desai is asking, when there are 2 or 3 differentials, then is there a phrase you prefer instead of diagnostic of?
No, diagnostic of is not common, and you use it only when you're diagnostic of. Otherwise, you describe all these findings. The differential diagnosis includes 1, 2, 3, and I tell resident 1, 2, 3, most likely first, least likely last. Simple. And what she must be doing is absolutely right. So when you have differential diagnosis, you have to give the differential diagnosis. So I use the word the differential diagnosis includes 1, 2, 3, and I teach residents you cannot say 4-legged animal, elephant first, cow next, and dog next. It has to be dog, cow, and elephant in that order. So that's it. I mean, it's perfectly fine. And that's the common thing. Often we are not sure. Then we give differential diagnosis. My point was that when you're sure, even then we use this, that. Or sometimes at least we should say diagnostic when it is really diagnostic. Okay, I hope this answers that question.
Absolutely. So one other question is, so if we do not use epicenter of the tumor, then what word would you use to, if there's a large mass and you want to say that, for example, it is arising from the uterus or the cervix, then
Okay, there's a very simple answer. First thing, I mean, please don't feel offended
yes, sir.
to whoever asked this question. The word epicenter is completely wrong. It's a foreign language as far as radiology reports are concerned. And there's a simple way, centered on, that's all. Instead of saying epicentered, you say centered around the head of the caudate nucleus, centered around the putamen of the whatever. You say, forget the epi. Epi makes it look that you don't understand the meaning of the word epicenter. So say centered on. So like you can say there was a traffic jam centered around the Prime Minister's house. You don't say it's epicentre around the Prime Minister's house. It's simple. It's quite simple. So delete the epi, use center, that's fine. It's perfectly correct English.
Got it. Maulik is asking if we see the same finding on multiple scans, so reporting a follow-up and there is hernia re-demonstrated or seen again, is there any phrase that you prefer to use in such settings? Would you use
So,
unchanged,
so,
seen again,
so you
re-demonstrated?
can say there is no change, and you can say the findings are similar when there is slight differences, or you can say the findings are identical. So you can say that there is no change from the previous radiograph, previous scan, which is not very right, because every time there's usually something. So you say the findings are similar to the previous finding or identical, depending upon what that is.
Got it. And Vivek is asking, when we are describing a mass, do we say, a lesion is seen? Or do you use the word seen? Or what would you
No,
use?
no, 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 no,
Or,
no,
uh, or,
no.
or,
There is a lesion, simple.
lesion. And calcifications are seen, calcifications are present, cavitation is seen. What would you
That's
use?
okay. Sometimes when you use that phraseology, it becomes normal. So the simple thing is don't use passive. Calcifications are seen, say it, there is calcification. This will take a long time to change because calcification are seen and all that passive tense is ingrained here. Okay. So if you want to change, it's very easy to change. There is calcification. There is mediastinal shift. There is hemorrhage. Instead of that, we keep using hemorrhage is seen, calcification is seen. It's just here. It's all here.
Absolutely, sir. Another anonymous question. If, for example, it's a CT neck, then is it okay to use the word the visualized lungs are clear?
Okay, it's not clear. I said, like that one, I said epicenter now. The word visualized is banned because we are not visualizing anything. And it's completely banned. So what you are seeing, so what I've started using for some time now, the part of the lung seen on this scan. That's all. Don't say visualize. I mean, that's wrong. I mean, I said right at the outset that we are not visualizing anything. So you have to find a way of saying the part of the lung seen on this, the part of the abdomen seen, so on and so forth. Or the part of the liver and the spleens on the chest scan. So it's simple. It's just that you have to change that phraseology. My objection is forget to visualize. Do not say visualize. That's all.
Perfect. So essentially, Vivek, figure out your own phrase, but it should not be visualized.
If I see visualize from Vivek, Vivek is in trouble.
Vivek is the person asking this. Vivek,
I don't know who the hell Vivek is, but obviously.
or at least he's not anonymous, so that's great.
Anyway, so
Perfect. And
I encourage anonymity because it's only through anonymity that you get true feedback. If you say that no anonymity, you don't get any feedback. People will say, oh, very good, very good, very good. So I'm a great supporter of anonymity.
no, so
I don't think it is wrong.
KEM sounding board didn't have anonymity. I remember that.
Sorry?
The KEM sounding board, I think there was no anonymity at that time, if I remember
No,
correctly.
we didn't allow it at that time.
Yeah.
But I also grow, no? Not
Okay.
only not no names are compulsory, your date and put your number, I mean time also in the sounding board.
Okay, so Pratyusha has a very good question. So she's
Yeah.
asking, for example, I'm seeing a specific finding, like I'm doing ultrasound and seeing internal echoes in the bladder, but the patient doesn't have any symptoms of a urinary tract infection. In such specific context, when I have a specific clinical correlation to recommend, is
Yeah.
it okay to then say, please correlate to rule out UTI?
No, here of course brings up a completely different ballgame. I wish I were an ultrasoundologist. I mean that at 72, I feel I should have been, because that's a golden opportunity to be with the patient. It's amazing how much better a radiologist can be if the patient is with you, or she or he, or if you have a patient in front of you and you have an MBBS degree, you have to ask 3-4 things: fever, difficulty in micturition, urine report. So what I would do if I were you, there are internal echoes there, but there are no clinical findings or this to suggest of urinary tract infection. Okay. And therefore, these findings are of undetermined significance. Again, if you don't want to do all that, you can say there are internal echoes findings which are consistent with urinary tract infection if clinical findings match. It's simple. It's a very simple language that you want to use. Rather than saying clinically correlate, you are saying that if patient has these symptoms, then these are consistent with urinary tract infection. Let me put it again. There are internal echoes seen within the urinary bladder, full stop. These findings are consistent with urinary tract infection if clinical findings match. And if you're doing ultrasound, you can say that these are the patient symptoms, therefore this is or this is not. That would require a little bit of guts to say that the patient has this or that or that. If you're 25, 30, you can't do that. But if you're 70, you can get away with murder. But don't just clinically correlate clinically. Say the other way around. Some of you feel that this is semantic. To me, this is not semantic. It changes the whole thing upside down. You are not telling the referring doctor, do something. You are saying that I am saying that if this is there, then this is that. I am making the diagnosis. And it also means that you are not telling me if these findings are there or not in your clinical notes. Okay, move on if there is anything more.
In fact, I agree. I also, at least from what I've seen in Tata, sir, is that often the language used in the report gets translated to the language spoken when you are talking with the referring physician. And that, in fact, becomes even more important because when we are talking with them, if we are not using the active voice,
Yeah.
instead everything is, a sort of defensive sort of way of speaking, then it reflects even more poorly on us. So in that sense,
You can monitor this. I
language.
mean, you can't do it. See if somebody else is talking to a referring doctor now, you'll find that there is more active voice because there is body language.
So
So you
yes.
convey your uncertainty in body language, eyes, hands, everything. But when you talk to each other, we seldom use a passive voice. I mean, you can search, see it for yourself and publish the voice of communication.
Got it.
Done?
I think so. I think we are done.
Okay.
Thank you so much for a really precious talk, which I think only someone like you can take. Such insightful stuff.
Talk English. Talk. We don't take talks. You give talks. What is this, Akshay?
Okay, sir. One more language to correct.
Oh God.
But I will also share with the attendees and the WhatsApp groups that I remember you have written a blog on this as well a few years ago. So I'll share that blog as well. But this is amazing. Thank you so much, sir.
Okay. Thank you. Thanks a lot.
Have a good weekend.
You too. Chalo, bye.